Hi, my name is Chris. Thanks for tuning in. Today I'm going to be going over the huge GynOnc landmark paper called PRIMA. Similar a little bit to Solo 1, but there are some stark differences. The main finding from PRIMA was that in patients with new diagnosis of advanced stage ovarian cancer, regardless of whether they were BRCA mutant or BRCA wild type, who underwent surgical management as well as a response to platinum-based chemotherapy, when placed on maintenance Niraparib, showed a significant increase in progression-free survival. That was a lot, but let's break it down in this entire video. Breaking down the background of this paper, we're focusing on PARP inhibitors. So that group of enzymes are responsible for single-stranded DNA repair mechanisms through base excision repair. These inhibitors bind to the NAD+ site, not letting it undergo its process. When we're looking at Niraparib, though, the NOVA study, which I haven't done yet, but I will in a future video, was looking at patients with recurrent ovarian cancer, and when they looked at Niraparib, they showed that there was an increase in progression-free survival. This was 21 months versus 5.5 months with BRCA positive, compared to the BRCA wild type arm, which was 9.3 months versus 3.9 months. This is medication versus placebo. So the question for this paper was, can you give maintenance Niraparib to patients who undergo initial management for advanced stage ovarian cancer instead of just waiting for them to go into recurrent? For the methods of this paper, these patients are at least 18 years of age with stage 3 or stage 4 ovarian cancer, either endometrioid or serous. These patients also included could be ones that had residual tumor left after primary debulking. They could be included if they had neoadjuvant therapy, if they were stage 3 inoperable. But before enrollment of the study, they had to have at least completed 6 cycles of platinum-based chemotherapy, max was 9 cycles, and the patients had their tumors assessed by MyChoice, which was a way to check for homologous end joining repair mechanisms. For the trial design, 733 patients were randomized between July 2016 and June 2018. They were randomized in a 2-to-1 fashion, receiving Niraparib versus placebo. They were continued on this medication for at least 36 months or until a disease progression. This was conducted in 20 different countries or 181 clinical sites total. So that's pretty much similar to what Solo 1 was. For the medication dosage, and I can show it right here, the plan was to start them on an initial dose of 300 milligrams once daily. This was continued on a 28-day cycle. So the patients received the chemotherapy after their treatment, then they were randomized, started on Niraparib or placebo within 12 weeks. And then they were followed Q12 week with a clinical exam as well as a CT/MRI to look for disease progression or recurrence. So they had imaging done at least, and they also could be assessed for clinical symptoms as well as CA-125 level. I'm gonna break down the classic table 1 for NEGM, and this is the comparison between Niraparib and the placebo group. I'm also going to want to compare the Niraparib group also to the Olaparib group that was shown in Solo 1. So here's the entire figure that you're already looking at, but now I want to compare some of the aspects. So looking at, PRIMA first, and then the second number I'll say is going to be the Solo 1. So for stage 3 in PRIMA was 65%, but it was actually 85% in Solo 1, where stage 4 in PRIMA is 35% compared to only 15% in Solo 1. So primarily a higher increase in stage 3 in Solo 1, where there's more advanced disease in PRIMA. When looking at the stage 3 patients, when you looked at primary debulk to R0, only 0.4% got that result within the PRIMA study, whereas 44% got it in Solo 1. They're pretty much the same on a histological standpoint, around 95% for both. For neoadjuvant therapy, though, 63% underwent that for PRIMA, while only 35% went it for Solo 1. And then when they looked at clinical response to chemotherapy, it was 75% for PRIMA and 82% for Solo 1. And then when you're looking at the number of cycles that was completed, when it was at least 6 cycles, or when it was 6 cycles, it was 66.8 versus 76%. And then we're looking at cycles 7 to 9, it was 21% for PRIMA and 23% for Solo 1. So the next part of this paper is figure 2, and this is the big meat of the paper. This is showing progression-free survival in the populations. They looked at, which was A, which was homologous recombination deficiency, and B was in the overall population. They called it homologous recombination deficiency because when they did the MyChoice test, what they were showing was any homologous recombination deficiency, not just BRCA. There's also subgroup analyses that will show BRCA, but we'll get into that a little bit. So to jump right down into the facts, and this is the results of the paper, when looking at the primary outcome, which is progression-free survival, in homologous recombination deficiency population, Niraparib was 21.9 months and placebo was only 10.4 months with a hazard ratio of 0.43. Overall, it was 13.8 months versus 8.2 with a hazard ratio of 0.62. When you took homologous recombination deficiency and you had to look at the supplemental tables, when they looked at BRCA mutant, it was 22.1 months for Niraparib, where it only was 10.9 months for placebo, hazard ratio of 0.4. When looking at BRCA wild type, so they had a different type of HRD, Niraparib was 19.6 months and placebo was 8.2, hazard ratio of 0.5. When they looked at HR proficient, which is the overall population, but the ones that actually had only homologous recombination active, the Niraparib was 8.1 and the placebo was 5.4, and this was a hazard ratio of 0.68. That last one's important because when you look at the overall population in figure 2b, it actually adds in the HRD population, so you don't get the pure HR proficient is what they refer to it as. So that's this unique population that PRIMA is attacking or targeting, because it's trying to say that, you know, providing Niraparib, which is a PARP inhibitor, to any population will be beneficial, even if they're BRCA wild type and if they are homologous recombination proficient. So that was a big thing. Secondary outcomes, this was overall survival, and this was within 24 months, and this was 10% of the population, so they had to extrapolate, and it was only published in 2019, so there's still tons of data. But the secondary outcomes, at least for the homologous recombination deficient, in 24 months, overall survival, Niraparib 91%, placebo 85%, hazard ratio of 0.61. For the overall population, it was 84% versus 77%, hazard ratio of 0.7. And then when you subdivided it and you looked at the HR proficient population, Niraparib was 81 and placebo was 59, hazard ratio of 0.51. The next figure we're looking at is figure 3. And what we're looking at is a subgroup analysis not specifically focused on homologous recombinant deficient or proficient. So this is other factors that Niraparib might be beneficial for in certain patient populations. So looking at this one, the important ones I want to point out is that when we're looking at progression-free survival in patients who had partial response to chemotherapy, whether or not they were homologous response deficient or proficient, Niraparib was 8.3 months and placebo was 5.6 months. So the administration of Niraparib had a hazard ratio of 0.6. When they had a complete response to chemotherapy, it was 16.4 months in Niraparib arm versus 9.5 months in the placebo, which is a hazard ratio of 0.6. So those are two big factors that have to show that maybe Niraparib is really beneficial in these other populations as well. The last thing I wanted to focus on was the safety profiles that were assessed in this population. So the big thing with Niraparib was the myelosuppression that was noted. For treatment-related grade 3, so this is patients who got Niraparib, this was anemia was noted in 31%, and roughly 65% in general had a grade 3 treatment-associated response, where only 6.6% had it in the placebo arm. And out of the 66%, 12% of those actually had to stop therapy because they had either low platelets or anemia or something like this. And this is also partially why, as I said earlier in the video, that there was a dose reduction from 300 milligram QD to 200 milligrams. So the last thing I wanted to just focus on was just the overall discussion. And I've been kind of weeding it through this entire presentation, but getting to the end of it, we're looking at this versus Solo 1. And PRIMA just broadened their differential and they included patients who are BRCA wild type. This could have been a little risky because you don't have synthetic lethality now, because you didn't have the 2-hit mechanism of hitting homologous recombination as well as PARPs. So this is a little bit different than Solo 1 in that factor. And they did show that even in patients who were homologous recombination proficient, which I think is the important part of this paper, they did show that there was a significant increase in the progression-free survival. I hope this video helps. I am going to be jumping obviously to the next video would be payola, and we'll go from there and see kind of the additional effects of PARP inhibitors within the realm of ovarian cancer. Thanks for tuning in. See you next time.